So, okay. Hematology. Now, hematology, let's start with anemia. Right. Now, again, we'll be using some of the concepts that we discussed in the long case. And by now, I think you might realize that if you study your clinicals very well and you have gone through those, the MCQs are easy. Especially the best response MCQs are easy because that always sort of refers to a clinical scenario. If you have listened to my teaching in long case, short case, emergency medicine, and sort of grasped everything, the best response should be quite good. True false එකේ ප්‍රශ්නේ තමයි ඔය theoretical එකක ලබ්බවල අහනවා and it's an outdated concept essentially ඔය මේ best true or false MCQ ලෝකේ කොහෙවත් නැහැ ලංකාවේ විතරයි තියෙන්නේ and all around the world where you doing more true best response හරි ඒක කමන්න කරන්න දෙයක් නැහැ right so I talked about anemia in the long case and we discussed the morphological classification of anemia and we classified anemia based on red cell indices and also features on the blood film into microcytic hypochromic anemia, macrocytic anemia, and normochromic anemia. So here we have the MCQ on the causes of microcytic hypochromic anemia. Make a lacing ගහගන්න පුළුවන් වෙන්න ඕනේ. Iron deficiency, sideroblastic, and anemia of chronic disease are the correct answers here. And here I again summarize the morphological classification of anemia. So microcytic, remember this classification is based on the red cell indices data as well as the blood film data. Right? And microcytic hypochromic anemia, there are 6 important causes. Right? The unusual ones are copper zinc deficiency, lead poisoning, and sideroblastic anemia. That's just a quick revision of the morphological classification. Now, if you have a patient with microcytic hypochromic anemia, it's very important to look at the iron profile. So once you diagnose the microcytic hypochromic anemia, then you have to do the iron profile. Right? Now, in classical iron deficiency anemia, you will have low serum iron and low serum ferritin. Right? So low serum iron and low serum ferritin. But in anemia of chronic disease, the serum ferritin will be normal or high. There are 2 reasons for that. Write that down if somebody asks in the long case. One, ferritin is an acute phase reactant. So whenever there is inflammation, the ferritin goes up. When there is inflammation, the ferritin goes up. That is one reason for the ferritin to be high. Okay. Another reason for the ferritin to be high in anemia of chronic disease is that the problem in anemia of chronic disease is there is impairment of release of iron from stores. That is the problem. Okay. In anemia of chronic disease, because of the inflammation that's going on in the patient, iron is not released from the bone marrow stores. So they have a low serum iron but high ferritin because of that. Okay, because iron is not released from the bone marrow stores. So there's ferritin, right? And bone marrow stores so that right? And then, but it cannot release the iron from these bone marrow stores. The body cannot release the iron from the bone marrow stores. Hari. Now let's talk about, and of course, if the ferritin is very, very high, you have to always suspect sideroblastic anemia, which is a sort of, if the serum iron is very high, you have to suspect sideroblastic anemia. Don't worry too much about that for the moment. Okay. Fine. True or false regarding iron deficiency anemia is the most common cause of anemia worldwide. Yes, it is, right? And if you take anemia worldwide, iron deficiency is very common because mainly nutritional deficiencies, right? In most parts of the world, including Sri Lanka, there is a high proportion of people who are nutritionally deficient in iron. So it is one of the commonest causes of anemia worldwide. May present with dysphagia, right? Now that's something special. These are some of the physical signs that you see in patients with iron deficiency anemia. So koilonychia, very brittle nails, spoon-shaped brittle nails, and also angular stomatitis, which is shown in the angle of the mouth in this picture. These are some signs that you get. Now remember that iron deficiency anemia can cause esophageal webs, right? And this is called Plummer-Vinson Mallory-Weiss syndrome, right? So esophageal webs. And these esophageal webs might sometimes present with dysphagia. So the A uttare hari, right? Dysphagia. Okay. Now I talked about this a little bit in that flow chart, right? And here you need to be able to compare iron deficiency anemia and anemia of chronic disease. One of the key differences is in both the serum iron can be low, but one of the main things is that the ferritin is higher in anemia of chronic disease. Because there are bone marrow stores of iron, the inflammation inhibits the release of this iron into the peripheral circulation, right? And then that is the problem. So their serum iron is low, but their ferritin is high. Okay. Serum ferritin is a reliable indicator of bone marrow iron stores. Now, MCQ in retrospect, now serum ferritin is not the best indicator of bone marrow iron stores, right? It's not the best, but you can take it as reliable, not the best maybe, because remember serum ferritin levels can be altered by inflammation. So the MCQ product ambiguous. Somehow an exam paper get and we usually have a meeting to discuss the answers. එතකොට අපි ඔය වගේම නිකන් A level වගේම තමයි. ඔය ඉඳලා හිටලා ambiguous statement එකක් දෙකක් ආවම ඒවට ඉතින් free marks දෙන්න පුළුවන්. Right? So serum ferritin is a reliable indicator of bone marrow iron. එක පොඩ්ඩක් අමාරුයි උත්තර දෙන්න, but you need to know the basis of this. Serum ferritin, yes, is a reliable indicator, but it's not the best indicator because it can be affected by inflammation, right? And inflammation increases the serum ferritin level. The best indicator of bone marrow iron stores is you have to stain the bone marrow with pearl stain, right? And you can see the iron staining in the bone marrow, right? That is the best indicator of iron, iron stores in the bone marrow. Okay. So pura percentage saturation can transfer in saturation table. Yeah, transfer in saturation. Right. Now, if you look at a blood film of iron deficiency anemia, you see microcytic hypochromic cells. So in this blood film, you can see a small lymphocyte here, and obviously the red cells are smaller than the small lymphocyte. So that is microcytic, and there is hypochromasia. Now, an important feature of iron deficiency is you see a lot of abnormal looking red cell shapes and forms. Various abnormal red cell shapes and forms api dakino. And that is called anisopoikilocytosis. Anisopoikilocytosis. And you can see these sort of pencil shaped cells, some teardrop cells, target cells. That is what you see in iron deficiency. So anisopoikilocytosis is a feature in the blood film. Right? And anisopoikilocytosis is seen in the blood film. Fine. Now, in patients with iron deficiency, the treatment of choice is obviously iron replacement, and you go for oral iron in most cases. And the target is usually about 300 milligrams of elemental iron per day. And there are various preparations which provide iron. Side effects are very common: nausea, vomiting, gastrointestinal side effects. Now, remember that it takes at least about 6 months for the iron stores to normalize in a patient with iron deficiency anemia. But actually, the initial response is an increase in the reticulocyte count. Because when you give iron, this iron can be incorporated into the red cells and then form reticulocytes, and the reticulocyte count increases. So that is one of the earlier changes that you see, right? Increase in the reticulocyte count within about 4 to 7 days. But it takes at least 6 months or sometimes even longer for iron stores to normalize. Right? So that is important to remember. And we talked about parenteral iron. Parenteral iron is very commonly used in patients with renal failure and also patients with heart failure. Both of these conditions are conditions where the gut is edematous. Renal failure, heart failure, the gut is swollen and cannot absorb iron. So the better way of giving iron is intravenous. And there is a faster bone marrow response with IV iron. MCQ right? Bone marrow store replenishment is much quicker with IV iron. But the actual hemoglobin response is the same, right? It takes the same time for the hemoglobin to come back up. But the actual bone marrow iron store response is quicker. Okay? Right. So if we go back to this MCQ lamai, statement iron stores are normalized within 6 weeks of therapy. Boru baila katawa. Beradi. So remember then, IV versus oral iron. IV iron is commonly used in patients with renal failure and heart failure because the problems in absorbing oral iron, and they replenish your iron stores very fast. Right. So Vaishnavan is asking, can sideroblastic anemia cause sideroblastic anemia? Vaishnavan is usually microcytic anemia. It is a bone marrow problem, but that what you get is a microcytic anemia usually. Right? Microcytic. Fine. Now next we come to anemia of chronic disease. Right? Anemia of chronic disease is a contributory cause for anemia in patients with rheumatoid arthritis. Harine katandare hari kisi prashnayak naha, true. Chronic inflammatory states are well known to cause anemia of chronic disease. Right. Devani එක low serum ferritin කිව්ව ගමන් වැරදි. Right. So anemia of chronic disease, remember I showed you, right? Anemia of chronic disease, remember I told you that the ferritin is normal or high because of 2 reasons. One is that ferritin is an acute phase reactant, and also it sort of is a there is a problem in releasing iron from the bone marrow stores. So bone marrow stores accumulate, ferritin goes up, but the iron cannot be released from that. Okay. This actually gives you the pathogenesis of anemia of chronic disease, but take a apita them බද්ධ වෙන්න දෙයක් නැහැ, වැඩි කරදර වෙන්න දෙයක් නැහැ කියන. Okay. Fine. Okay. Right. Reticulocytosis එකක් එන්නේ. Reticulocytes are usually lower. How do you treat anemia of chronic disease? Doesn't respond to iron therapy very well, but there is now evidence. මේ pathophysiology diagram එකෙත් පොඩ්ඩක් තියෙනවා මේක ළමයි. There is we have found that in anemia of chronic disease, apart from this impaired release of bone marrow iron, that there is a erythropoietin suppression here. The inflammation suppresses erythropoietin, right? Suppresses erythropoietin here. So what happens there is, now we are using sometimes in patients with severe problems, right? We use erythropoietin. So severe anemia of chronic disease, there is a role for erythropoietin, because now we understand that the inflammation, as you can see, may BC inflammation, there is inhibition of erythropoietin release as well as some reduction in the response to erythropoietin, right? So that is what you see. Okay, so now we use sometimes erythropoietin for anemia of chronic disease. Right. Now, as you know, B12 and folate deficiency causes a macrocytic anemia. It's a macrocytic megaloblastic anemia. Why do we call it a megaloblastic anemia? Because there are megaloblasts in the bone marrow, right? So megaloblastic macrocytic anemia occurs due to B12 deficiency and folate. Megaloblastic, again, I remind you, that is a bone marrow diagnosis, right? Increased megaloblasts in the bone marrow. Okay. Fine. B12 deficiency is seen in patients with autoantibodies against intrinsic factor. This is what is this? Pernicious anemia, right? Intrinsic factor is essential to absorb B12. Right? So this is pernicious anemia. Pernicious anemia. In the blood film, what do you see? These are some causes of B12 and folate deficiency, right? In the blood film, what you see in B12 deficiency is oval macrocytosis. Oval, round neve oval macrocytosis with hypersegmented neutrophils. Right. Now, round macrocytes neve oval macrocytes. Now, an unusual thing about B12 deficiency is that it causes neurological syndromes, right? Neurological syndromes in our, right? In B12 deficiency. This is something you don't see in folate, right? The classical neurological disease in B12 deficiency is subacute combined degeneration of the cord. That is the typical story. And you can also get a bit of dementia as well, right? You can also get a bit of dementia, right? Another unusual thing about B12 deficiency, which can be asked in the MCQ, is you can get a bit of hemolysis, right? A bit of hemolysis in B12 deficiency. This is actually a hemolysis that occurs in the bone marrow, because these abnormal red cell forms start breaking down in the bone marrow, right? And causes a hemolysis inside the bone marrow. So somebody gives an MCQ, there is a mild hemolysis also associated, right? There is a mild hemolysis that occurs because of bone marrow red cell breakdown, right? This abnormal immature red cells, these blasts, sort of break down inside the bone marrow, where there is lack of B12. Right. How do you treat B12 deficiency? It is intramuscular B12. Oral B12 is useless, right? You need to give intramuscular B12. Right. Okay, that is about B12 deficiency. Right. Now, when we are doing the long case discussions, we talked about jaundice and hemolytic anemia. Right. So I'm just reminding, in the hepatology MCQs also we covered this area. So remember, hemolytic anemia, there are certain, right? There are certain common things, right? Right. Janet, the question that you're asking, folate B12 deficiency, ඒක biochemistry වලට උගන්වලා ඇති නේද? Yeah. Biochemistry වලට උගන්වලා ඇති. පොඩ්ඩක් එක මතක් කරගන්න. ඔය B12 the folate ඉස්සෙල්ලා දෙන්නේ කතන්දරේ ඒකේ basis එක. හරි? Okay. Right. Hi. Okay. Right. Now coming back to hemolytic anemia, lamai. Right, sorry. Hemolytic anemia, jaundice with indirect hyperbilirubinemia. And there are certain other common features of hemolytic anemia, general features of hemolytic anemia, which are useful for your long case discussions as well as your MCQs. So it is an indirect hyperbilirubinemia. Also, what happens is, because of red cell breakdown, red cells contain the enzyme LDH, so LDH levels go up. So in hemolytic anemia, across all types of hemolytic anemia, the LDH will be higher. When the red cells start breaking down in the peripheral circulation, the bone marrow goes crazy. Okay? Red cells are breaking down in the peripheral circulation. Bone marrow is overproducing red cells. Overproducing red cells, so increased erythropoiesis, and pushing out abnormal red cell forms. And these are abnormal early red cell forms, which are reticulocytes. So apart from what you see, indirect serum bilirubin, LDH elevation, you also see that there is increased erythropoiesis in the bone marrow and also reticulocytosis. Right? So these are common features of all types of hemolytic anemia. Right. So serum LDH is elevated, indirect hyperbilirubinemia. Then indirect hyperbilirubinemia and increased reticulocytes, and also erythropoiesis increasing in the bone marrow. If you were to do a bone marrow, you will see that there is increased erythropoiesis. Okay, increased erythropoiesis. Fine. The hypercellular marrow with increased erythroid ratio is typical. Right. Now, apart from these general features, there are specific features of intravascular hemolytic anemia versus extravascular hemolytic anemia, right? Intravascular versus extravascular. Extravascular hemolysis can in the liver and spleen. But some hemolytic anemias, the hemolysis can occur inside the vessel. This is intravascular hemolysis. Intravascular hemolysis, right? So what happens is, when there is intravascular hemolysis, there is release of hemoglobin, free hemoglobin. This free hemoglobin binds to haptoglobulin in the serum. The serum protein of, there is a serum protein called haptoglobulin. The free hemoglobin binds to haptoglobulin. So there will be decreased free serum haptoglobulin. Okay, reduced free serum haptoglobulin in intravascular hemolysis. Also, this hemoglobin is excreted in the kidneys, right? So they can get hemoglobinuria, and then hemosiderin is a sort of breakdown product of hemoglobin, right? Hemosiderin in the right? And Shams test can hemoglobinuria test dipstick test. So because of the release of hemoglobin into the circulation, they have low serum free haptoglobulins and hemosiderin and methalbumin in the urine, right? And hemoglobin as well in the urine, right? A features, and sometimes chronic intravascular hemolysis can lead to iron deficiency anemia. Blood chronic intravascular hemolysis can sometimes lead to iron deficiency. It's an uncommon cause of iron deficiency, but it can happen, and I have seen plenty of cases. And serum haptoglobulin is increased, reduced. So free serum haptoglobulin is reduced in intravascular hemolysis. So you should know the general features of hemolytic anemia, plus work out some of the specific features and comparing intravascular, extravascular hemolysis. Okay. Right. Now, we talked about this classification of hemolytic anemia, right? We talked about this classification of hemolytic anemia into hereditary and acquired. Hereditary hemolytic anemias are subclassified into 3: membrane defects, enzymopathies like G6PD deficiency, and hemoglobin defects like thalassemia. Acquired ones, you have mainly the immune stuff, but there are other causes also. Right. Okay. So let's talk about a few causes of hemolytic anemia. Few causes. Number one. So in the congenital variety, I told you there were three subtypes. Membrane defects, metabolic defects like G6PD deficiency, and also hemoglobin defects like thalassemia. These are the three things that you will see. Of these, hereditary spherocytosis is an autosomal dominant disorder. Right? Hereditary spherocytosis is an autosomal dominant disorder. G6PD deficiency is an enzymopathy. It is an X-linked disorder, as you know, and hemolysis occurs under oxidative stress. G6PD deficiency. What happens is hemolysis occurs under oxidative stress. Famous things are anti-malarial drugs. Primaquine, another newer drug is something called tafenoquine. Tafenoquine. They came a hemolysis in puluwang. Right. And there are certain other food substances that can also cause hemolysis in G6PD deficiency. Right. Now, when it comes to the acquired ones, I told you the main thing is autoimmune hemolytic anemia, and Coombs test is usually positive in these people, right? But there are also other types of acquired hemolysis like fragmentation syndromes, red cell fragmentation syndromes. Apart from the autoimmune or immune mediated ones, you have these red cell fragmentation syndromes. Red cell fragmentation syndromes, things like HUS, TTP, and patients with mechanical valves. Because the mechanical valve is red cell cadeno, right? So these can cause fragmentation of red cells. So this is just an overview of the causes of hemolytic anemia, right? One of the causes right? Any questions up to now? So jaundice, you can't differentiate jaundice due to intravascular and extravascular hemolysis. That doesn't work that way. Right? So a few more details about hereditary spherocytosis in this slide and G6PD deficiency. So, list drugs list hereditary spherocytosis MCQ it commonly presents with gallstones, and this aplastic crisis can be seen with parvovirus B19 infection in patients with hereditary spherocytosis. ඇති වැඩ කරේදී ලබන්නේ නෙවෙයි, නමුත් මම MCQ වල දැකලා තියෙනවා, පරණ MCQ වල අහලා තියෙන පිස්සු මොකක් ආවුවත් දන්නේ නැහැ. මම පේපර් එක දුවත් නම් ඌ වගේ ලබ්බවල අහන්නේ නැහැ. හරි? So yeah. Okay. Fine. Right. Now thalassemia is a pediatric topic. Sorry. Yeah, so I'm not going to go into detail about thalassemia. Yeah, it's a pediatric topic and classification එක ඔයගොල්ලෝ හොඳට pediatric වල කරලා ඇති, medicine වල වැඩි අහන එකක් නෙවෙයි. හරි? ඒ නිසා මේක ගහ ගන්න පුළුවන් වෙන්න ඕනේ කිසි කරදරයක් නැතුව. හරි? So HBE disease with beta thalassemia is known to occur in Asia. That is true. Microcytic hypochromic anemia එකක් තමයි එන්නේ. And thalassemia major, you actually see nucleated red cells in the blood film, as well as a microcytic hypochromic picture. Right? Nucleated red cells උත් දකින්න අපි සමහර වෙලාවට. Oops, sorry. Right. So we talked about fragmentation hemolytic anemias like DIC, HUS, TTP. These are all fragmentation syndromes. Right? Fragmentation syndromes. And I told you in the OSCE discussions one of the main differences between DIC and HUS-TTP is in DIC, you get significant abnormalities in coagulation tests, right? Significant abnormalities in coagulation tests, PTINR, APTT, and TT, thrombin time. But in HUS-TTP, the coagulation tests will be normal. Point. So we'll do some MCQs and see now. True or false regarding autoimmune hemolytic anemia? So I told you in the acquired group of hemolytic anemias, autoimmune hemolytic anemias are very important. Right? Autoimmune hemolytic are very important. There are two types of autoimmune hemolytic anemias that we see. One is warm autoimmune hemolytic anemia, and the other one is cold autoimmune hemolytic anemia. Acrocyanosis is seen in Mogel. Acrocyanosis can, remember your peripheries are cooler, right? So in patients with cold autoimmune hemolytic anemia, they get acrocyanosis. So there is hemolysis at the peripheries in the fingers because it is cooler than the central parts of the body, right? That is important. Cold autoimmune hemolytic anemia ගැන MCQ point එක මේ table එකේ තියෙනවා, right? Yeah. So usually cold autoimmune hemolytic anemia is an IgM antibody, which responds best, or sort of reacts best with antigen at a low temperature. And it activates a lot of complement mediated lysis, right? Complement mediated lysis of red cells. Whereas warm autoimmune hemolytic anemia is mostly IgG mediated, right? So these are some differences, right? Another big difference between the two is cold autoimmune hemolytic anemia usually is intravascular, while warm is extravascular, right? Warm is mostly extravascular. Right? As causes ටිකක් පොඩ්ඩක් මතක තියාගන්න ඕනේ ලයිස්තු වගේක් මෙතන තියෙනවා. Cold autoimmune hemolytic famously due to mycoplasma, right? Famously due to mycoplasma infection. And also things like lymphoma and CLL. Right? Cold එක. Warm එක SLE, rheumatoid arthritis, inflammatory bowel disease, and also can occur in CLL. IMN can cause cold autoimmune hemolytic anemia, but sometimes warm, mostly cold. IMN වලට mostly cold එකක් තමයි. Right. So MCQ ටිකක් එතන දැනගන්න ඕනේ. Methyl dopa causes autoimmune hemolytic anemia, that is true, and mostly මේ list එක බැලුවොත් එතන මෙතන list එකේ නැද්ද? ඒක මෙහෙමයි. ඒකේ warm cold දෙකම ඉන්න පුළුවන්. එහෙම විශේෂ ලොකු වෙනසක් නැහැ. Mycoplasma. Sorry, methyl dopa. Right. Now, when we are doing the data interpretation and blood films in the OSCE classes, I told you that when you have hemolytic anemia, most of the time it is normocytic or macrocytic, right? Normocytic or macrocytic. Write down, there are two reasons for this to be, or three reasons for cells to be macrocytic, right? One of the main reasons is that in autoimmune hemolytic anemia, red cells stick to one another, right? And this causes red cell clumping. When the machine reads a red cell clump, it reads it as a single cell, right? So because all these red cells are sticking to one another, they cause the red cell clump, and the machine reads this as a single red cell. Loku pata red cell එකක් විදියට කියවන්නේ. So that is a main reason for increased MCV. Right. Another reason for increased MCV is that when there is hemolytic anemia, there is release of reticulocytes from the bone marrow, right? And these reticulocytes, again, when you put them through the machine, they are read as big red cells. Reticulocytes are bigger, and they cause an increased MCV when you do a machine read. Another reason for increased MCV is, remember, when there is hemolysis, the bone marrow starts going crazy and increased proliferation in the bone marrow. When there is increased proliferation, it uses up a lot of folate, right? So you can get a secondary folate deficiency, right? And that can cause a macrocytosis also. Okay. Hi. So the MCV වෙන්නේ හේතු තුනක් කිව්වා. Because of red cell clumps, because of reticulocytes, and also because of the secondary folate deficiency. The reason is because the bone marrow is proliferating at a much higher rate, trying to compensate for the red cell breakdown. එළියට දානවා පුළුවන් තරම් එළියට දාන්න හදන්න. හරි? ඒක. Fine. Okay. Warm autoimmune hemolytic anemia is IgG mediated කියලා අපි කිව්වා. Cold autoimmune hemolytic anemia is IgM mediated කියලා අපි කිව්වා. Warm autoimmune hemolytic anemia responds very well to steroids. Cold does not. Right? So cold hemolytic anemia is very difficult to treat. It doesn't respond very well to steroids, but warm does respond nicely to steroids. So they respond better. So පස්වෙනි එකත් වැරදි. So I assume that you have got a relatively good picture now of the differences between warm and cold autoimmune hemolytic anemia. Any questions up to now? ප්‍රශ්න තියෙනවද ළමයි? Right. Okay. Now, question number 9 is on aplastic anemia, not a very important topic for undergraduate because it's a very complicated thing. Right? I've just given you some causes of aplastic. Aplastic anemia is essentially a bone marrow failure, right? Which is can be inherited or acquired. And I've given you some causes, right? The bone marrow fails and is replaced with fat globules, right? That is what you need to know. Very difficult to treat, and sometimes they require bone marrow transplants. Okay. So let's move on now to hematological malignancies. Now, of the hematological malignancies, for adults, again, there is an overlap with pediatrics here. In adults, the most important hematological malignancy that can appear in an exam is CML, right? CML, right? Chronic myeloid leukemia. Now, this is the typical appearance of chronic myeloid leukemia on a blood film. And you would have seen this when we did our OSCE classes. So chronic myeloid leukemia, there is an increase in the number of myeloid cells, right, in the peripheral blood, right? And remember, there are stages of differentiation in the peripheral blood in chronic myeloid leukemia. So there are mature myeloid cells, mature neutrophils, and mature myeloid cells. But there are also immature blast cells as well, which you can see in this picture. So there are blast cells and more mature cells. So you have a range of differentiated forms in the blood film in chronic myeloid leukemia, and they have a very high white count and a high myeloid cell count. Right. Okay. Chronic myeloid leukemia is not associated with hemolytic anemia. CLL, however, is. Right. Right. Chronic lymphocytic leukemia is associated with hemolytic anemia. Right. Now, how does chronic myeloid leukemia present? Right. Sometimes they might have constitutional symptoms like fever. Bone marrow failure is a feature because the bone marrow is full of abnormal myeloid cells. It suppresses the other cell lines, right? Causes anemia and bleeding because of low platelet count. It suppresses the other cell types within the bone marrow, right? Within the bone marrow. Okay, fine. Another feature that you might see is that they have leukostasis, increased viscosity because of the very high white cell number in their peripheral blood. Right. But remember, splenomegaly is by far the most important manifestation of CML, and it is one of the causes of massive splenomegaly. And it corresponds with the tumor burden. So bigger the tumor burden, the more the spleen, bigger the spleen, right? Bigger the spleen. Right. So can cause massive splenomegaly. Thrombocytopenia is common, common but can occur. Right. Can occur. Right. Now, in the management of CML, most people have a good prognosis and a chronic state. Right? It's a chronic malignancy. It's not very aggressive malignancy. Sometimes people might manifest into an accelerated phase, right, which resembles an acute leukemia, but most of the people are happily in a chronic state, right? And most of the time, these people who are stable and are in a chronic state have this Philadelphia chromosome, which is a 922 translocation. It's a BCR-ABL translocation. So that is called a Philadelphia chromosome. And most of these people who are chronic, stable disease, good prognosis, have a positive Philadelphia chromosome. But people who present with a acute leukemia-like picture or progress into a very accelerated phase or blast phase are negative for Philadelphia chromosome. So Philadelphia chromosome is positive in the majority. Yes, Philadelphia chromosome is positive. I have a better prognosis. They are most in the chronic phase. Philadelphia chromosome negative people are in major trouble because they progress into accelerated phases and blast crises. So not good. Right? So Philadelphia chromosome negative people have a poor prognosis. Another thing about Philadelphia chromosome positive and negative CML is that Philadelphia chromosome positive people respond very well to medication, and imatinib is the drug of choice. Imatinib is the drug of choice, which is a tyrosine kinase inhibitor. Tyrosine kinase inhibitor. And you can actually see, BCR-ABL mutation level imatinib. That's a very nice thing and used for treatment monitoring. So that's called a BCR-ABL transcript level monitoring. Gene mutation and when you give imatinib, the levels go down. Right? The levels go down when you give imatinib. So imatinib is a drug of choice, and people with a positive Philadelphia chromosome respond much better to imatinib. Okay. Any questions about CML? Okay. Now, when it comes to lymphoma, lymphoma again is a very complicated area. Very, very complicated area. At an undergraduate level, we talk about Hodgkin's lymphoma and non-Hodgkin's lymphoma. Now, hematology has gone a long way since over the last 5 or 6 years, because there's a lot of genetics and immunology in hematology now. And this concept of Hodgkin lymphoma, non-Hodgkin lymphoma is getting out of date now. Because now most of these lymphomas are managed based on their immune profile and bone marrow cytogenetics and various complicated things. In some exam but this Hodgkin, non-Hodgkin is a relatively old concept. The name comes is Hodgkin's lymphoma has a classical cell in the histopathology, right? And that is called the Reed-Sternberg cell. It is supposed to have an owl-like nucleus. Owl-like nucleus. Non-Hodgkin's lymphoma doesn't have Reed-Sternberg cells. Now, Hodgkin's lymphoma typically starts in one lymph node group and has a contiguous spread. බෙල්ලෙන් පටන් අරන් chest එකට ඇවිල්ලා chest එකෙන් බඩට යනවා. ඒ වගේ. And commonly the nodes above the diaphragm are affected in Hodgkin's lymphoma. So it starts commonly in the cervical region in one lymph node group, and it's a contiguous spread, spreads from one lymph node group to the other, and commonly affects the lymph nodes above the diaphragm. Right? Hodgkin's lymphoma is a nice set of symptoms called B symptoms. Right? B symptoms කියලා තියෙනවා. Right? B symptoms, weight loss, night sweating, අපි මේවා කතා කරලා තියෙනවා in the long case, and fever. Right? Okay, very rarely Hodgkin's lymphoma can affect the bone marrow, so it can have a extranodal involvement. Bone marrow එකට යන්න පුළුවන්, blood වලට යන්න පුළුවන්, right? Extranodal involvement. Very rare. Now, in compared to this, non-Hodgkin's lymphoma does not have Reed-Sternberg cells in the histopathology, and ඒක පිළිවෙලක් නෑ, හරිම aggressive එකක්, right? පිළිවෙලකට යන්නේ නෑ. There is very common extranodal spread, bone marrow involvement, right? Blood එකට එනවා හරි කචල් එකක් ඒක, right? So that is a more sort of aggressive, badly behaved lymphoma. Whereas Hodgkin's lymphoma starts in one cell and one lymph node group goes to another one. Very nice contiguous spread and contiguous progression එකක් තියෙනවා. Non-Hodgkin's වල ඒක කචල්. එහෙම වෙන්නේ නැහැ. කිසි පිළිවෙලක් නැහැ. ඒකේ හැසිරීම. හරි. You can go to bone marrow and blood. So using that concept, let's go through this MCQ. Hodgkin's lymphoma is characterized by the presence of Reed-Sternberg cell. Hari. Non-contiguous නෙමෙයි Hodgkin's lymphoma. එක lymph node group එකකින් තව lymph node group එකට ලස්සනට යනවා. ඒකට කියන්නේ contiguous spread එකක් තියෙනවා කියලා. එකින් එකට ලස්සනට යනවා. Extranodal involvement is common with non-Hodgkin's lymphoma, where the lymphoma spreads outside the node into the bloodstream and into the bone marrow. Hodgkin's lymphoma is known to present with paraneoplastic syndrome එක හරි, right? දෙකේම එනවා. non-Hodgkin වලට වැඩිපුර එන්නේ, but මේකෙත් එනවා. Remember, Hodgkin's lymphoma is a diagnosis based on lymph node biopsy and histopathology, right? You need tissue diagnosis, right? Diagnose any sort of lymphoma, you need a tissue diagnosis. LDH is elevated, but it's not diagnostic. Some people use LDH to assess treatment response, but LDH වැඩි කියලා lymphoma diagnose කරන්න බැහැ. The diagnosis of lymphoma needs a tissue-based diagnosis. It's a tissue-based diagnosis. බුද්ධිමාද වන්ද bean symptoms එනවා non-Hodgkin's වලත්, but commonly with Hodgkin's. Right? Commonly with Hodgkin's. දැන් මම කිව්වා මේ concept එක පොඩ්ඩක් outdated මේක. නිකන් ඇහුවොත් කියලා මම දැම්මේ. Hematology has gone a long way when it comes to lymphoma, and people have so super specialized in lymphoma ජාති වල super specialized කරපු මිනිස්සු ඉන්නවා, and it's mostly based on cytogenetics, immunology ඔය වගේ නිකන් වෙනස් පැත්තකට ඔය ගිහිලා තියෙනවා. Okay, right, so those about lymphoma. Now the next MCQ number 12 is on multiple myeloma. Multiple myeloma ගැන බලමු අපි කාට. Now, multiple myeloma, to introduce it, is a malignancy of plasma cells. And remember that these cells produce a monoclonal antibody, right? So there's only one clone of plasma cells that produces one type of antibody, monoclonal antibody production. One type, right? And sometimes it's only light chains දෙකම හැදෙනවා in an antibody molecule, right? This antibody has a light chain and heavy chain. මේ දෙකම වැඩි වෙනවා, but sometimes some types of myelomas only produce light or heavy chains. Multiple myeloma is a disease of the elderly, so 65 plus වගේ තමයි ගොඩක් වෙලාවට එන්නේ. In young people it is very uncommon, very uncommon. Now we have talked about these investigation findings in myeloma, and these are frequently asked in MCQs and even in long cases, right? So myeloma causes a norm. The typical presentation of myeloma is an elderly person presenting with backache, anemia, and increased TSR. Right? So that is a typical presentation. So they have an elderly person coming with backache, anemia, and increased TSR. That is classical of multiple myeloma, very typical of multiple myeloma. Very typical of multiple myeloma. Right. So how do you diagnose multiple myeloma then? Sorry, blood film, you will see rouleau formation. Rouleau formation in the blood film. Rouleau formation. Okay. How do you diagnose multiple myeloma? One, you need to demonstrate monoclonal gammopathy, right? Because that is the hallmark of the disease, increased monoclonal antibodies. So monoclonal gammopathy, you can use electrophoresis or something called immunofixation, right? Electrophoresis or immunofixation, right? And then remember, multiple myeloma, once you have demonstrated that there is monoclonal gammopathy, you need to demonstrate that there is end organ damage. So that will be lytic lesions in the bone marrow, renal impairment, hypercalcemia, right? So we demonstrate karan. So once you demonstrate the monoclonal protein, you have to demonstrate that there is end organ or target organ damage with bone marrow lytic lesions, hypercalcemia, and also renal impairment. And it can cause renal amyloidosis as well, because these abnormal proteins when deposit in the kidney. So multiple myeloma typically causes sclerotic lesions in long bones. So these are lytic lesions in flat bones usually. Lytic lesions in the skull are very typical of multiple myeloma. Renal amyloid, organ damage can be hypercalcemia, lytic lesions, renal impairment, renal amyloidosis. Diagnosed monoclonal gammopathy, not polyclonal gammopathy. Right? And this is an important point. ALP is usually normal in myeloma. ALP is usually normal in myeloma, unless there is a fracture. ALP is usually normal in myeloma. ALP is normal in myeloma, except when there is a fracture. When there is a fracture, it goes up. This is completely different when you talk about metastasis. Metastasis, the ALP is sky high, right? But in myeloma, the ALP is normal unless there is a pathological fracture. So, suspect multiple myeloma in elderly person with backache and anemia. Diagnosis is with and rouleau formation in the blood film. Confirmation is with, you have to do the monoclonal proteins, you have to show that there is end organ damage, and you have to also do a bone marrow to demonstrate the excess of plasma cells. Beta-2 microglobulin is used as a prognostic marker. True. That is one of the prognostic markers that we use. Not for diagnosis, but prognostic marker. Right. Make it don't worry too much about that. Okay, so those are all the hematological malignancies. Any questions? Yeah, so multiple myeloma, ultimately you have to do a bone marrow. Ultimately you have to do a bone marrow, and that is where the diagnosis is confirmed. But you have to do the පිළිවෙලට. පාට bone marrow කරන්නේ. Monoclonal protein එක පෙන්නන්න ඕනේ, organ damage පෙන්නන්න ඕනේ, and then bone marrow කරන්න. Right? So you have to go in sequence. CLL presentation is a bit unusual. They commonly present with lymphadenopathy. Right? Again, CLL is a very stable type of malignancy. It's not very aggressive. So they can just present with just lymphadenopathy and white count showing a lot of lymphocytes. Yeah, so lytic lesions can occur in the long bones also, but commoner in the flat bones, like the skull pelvis. Bence-Jones protein is not specific to multiple myeloma. Bence-Jones protein can නිකන් අර protein එක බද්දර urine අරගෙන රත් කරනකොට precipitate එකක් එනවා, and then you keep on heating it, it disappears. Right. Anemia treatment in myeloma is a bit complicated. You don't have to worry about those sorts of things. So there is no best investigation to diagnose myeloma. The definitive diagnosis is in the bone marrow, but bone marrow එකක් කරන්න කලින් කරන්න දේවල් තියෙනවා. So it is a diagnostic criteria. There is no single diagnostic test. So in the diagnostic criteria, you have to show monoclonal gammopathy. You have to show that there is organ damage, and then you have to confirm with that you do the bone marrow. තේරුණාද? ඔය තුනම තියෙන්න ඕනේ diagnose කරන්න. එකකින් diagnose කරන්න බෑ. Hi. Okay. Now, question number 13 is on myeloproliferative disorders. Now, myeloproliferative disorders, we talk about three important myeloproliferative disorders. One is CML is included in the myeloproliferative disorders also. Polycythemia rubra vera, where there is increase in the red cell production in the bone marrow, polycythemia rubra vera. And then essential thrombocythemia, where there is increased platelets. There is another one which is called myelofibrosis, where there is increase in the fibroblasts in the bone marrow. So these are the main myeloproliferative disorders. Now let's talk about polycythemia rubra vera. So obviously how you diagnose it, the hemoglobin will be high. Hemoglobin and the red cell mass will be very high in polycythemia rubra vera, right? Hemoglobin and red cell mass will be very high. What happens if you measure their erythropoietin levels? So they are polycythemic, their hemoglobin is high, red cell mass is high, hematocrit is high. Right? That is how what you see, right? That is what you see. If you measure the erythropoietin levels in polycythemia rubra vera, what will happen? Kalpana කරලා හිතන්න පුළුවන් නේ. When there is increased red cell production, the erythropoietin levels are suppressed. So they have lower erythropoietin levels. Lower erythropoietin levels. Okay. Diagnosis is clinical plus you do the increased hemoglobin, HCT, red cell mass, and low erythropoietin. All of that are in favor of a diagnosis of polycythemia rubra vera. And then most of these people are JAK2 mutation positive, right? Most of the people with polycythemia rubra vera are JAK2 mutation positive, right? Blood film එකේ teardrop cells එන්නේ myelofibrosis වල කියලා මතක තියාගන්න. PRP වල නෙවෙයි. And myelofibrosis causes something called ඒකේ පොඩි nucleated red cells, white cells ටිකකුත් තියෙනවා with teardrop cells. That is myelofibrosis. Myelofibrosis. PRP treatment එක you use venesection. Some people give hydroxyurea, that is to prevent the cells in the bone marrow from proliferating. Hydroxyurea කියන එක පාවිච්චි කරනවා ඒකට. Right. So බලන්න MCQ එක හරිනේ නේද? අනේ මට කියන්න අමතක වුණා arterial venous thrombo එක හිතලා ගහන්න පුළුවන් නේද? When there is increased red cell mass, increased red cells, there is thrombosis because of the hyperviscosity, right? Hyperviscosity. And then that is another unusual symptom is Mahesh, yes, you get this name. නානකොට ඇඟ කසන්න ගන්න ගතියක් තියෙනවා. ඒකට විශේෂ හේතුවක් නැහැ මම දන්න විදිහට. හරි. splenomegaly, yes, Purna, like 100% and main Kira Dilatino, splenomegaly, PR, any myeloproliferative disorder can cause splenomegaly, right? And then serum erythropoietin aduiki and kahari, teardrop cells, sevatic hari. Somebody asked acute leukemia, chronic leukemia. So acute leukemia, chronic leukemia is differentiation is based on the marrow plus the peripheral blood. Like a pediatric one, by the way. So acute leukemia, the peripheral blood, there are also blast cells, only blast cells. In chronic leukemia, as I showed you in the CML slide, there is a mixture of normal looking cells or mature cells and blast cells. And also there are lots of other genetic tests and special stains that are used to differentiate acute from chronic leukemias. But even from the blood film, you can suggest acute leukemia because acute leukemia ke only blasts. In chronic leukemia, you get a mixture of blasts and mixture of blasts and mature red cells. Dekama dakino. Hari dekama dakino. මේක අපි බලන්නේ මේ mixture of blast cells and mature cells දෙකම තියෙනවා. Okay. So finally we have the bleeding disorders. Again මේ වගේ MCQ හදන්න හරිම ලේසි. අර කම්මැලි කමට අපිට මේ MCQ හදාගන්න බැරි වුණාම හදන එකක් තමයි මේ වගේ ප්‍රශ්න. හරි? Causes of thrombocytopenia. ඕන මගුලක් හරි ඉතින් ඕක ගැහුවොත් එහෙම. හරි? And here is a long list of causes of thrombocytopenia. Right. ITP. Now ITP is an important, it's not the commonest cause of thrombocytopenia, but it's an important cause of thrombocytopenia. Right? And the problem here is that there are antiplatelet antibodies, which cause a platelet breakdown, right? ITP can occur, or ITP-like picture can occur in certain secondary disorders like SLE and HIV. An important point to remember is ITP is not associated with splenomegaly. MCQ එකක් නැද්ද? It's unusual. හරි. MCQ එකක් නැහැ. But essentially when you have chronic ITP, treatment is initiated based on their symptoms and their platelet counts. Right? And usually most of them bleeding with platelet count less than 30,000 තමයි පටන් ගන්න. And the treatment of choice is steroids. But sometimes you have emergency presentations where they have life-threatening bleeding, right? ඒ වගේ වෙලාවට you use steroid pulses, IVIG, anti-D රෝගම් සමහර අයට දෙනවා, right? And in some cases, when there is profound life-threatening bleeding, dangerous life-threatening bleeding, platelet transfusions are also used. Platelet transfusions. They are emergency presentation. Hari. ඔය මේ වගේ MCQත් ඉඳලා හිටලා අහනවා මේක පොඩ්ඩක් බලාගෙන යන්න ළමයි මේ එක එක coagulation test අඩු වැඩි වෙන ඒවා ටිකක් මේකේ තියෙනවා. ඔය ඉඳලා හිටලා MCQ වලට අහන්න. හරි. Right. Hemophilia is again a pediatric topic, not very important for medicine. හරි. මේක ගැන වැඩි කලබල වෙන්න එපා. Okay. Right. So let's go to the best response MCQs now. අපි theory එක දාන නිසා මේක ලේසි. So some story palop with vitiligo. Vitiligo තියෙනවා කියන්නේ autoimmune පැත්තට බර කතාවක් තමයි මේ කියන්නේ යන්නේ කියලා පේනවා. MCV is high, right? And there is a bit of hemolysis. If you have read this question carefully, there is a bit of hemolysis. And පොඩි pancytopenia ගතියකුත් තියෙනවා. right. දැන් අමාරු ප්‍රශ්නයක් ඒක. මොකක්ද මේක උත්තරේ? So hemoglobin අඩුයි, there is a bit of a barrow failure වගේ කතන්දරයකුත් යනවා. MCV එකත් වැඩි ගොඩක්. And bilirubin එකත් hemolysis එකකුත් යන්තම් යනවා. මොකක්ද මේ? vitiligoත් තියෙනවා. autoimmune කෑල්ලකුත් තියෙනවා. හරි? So මොකක්ද මේ කතන්දරේ? right. සජිත් ankle edema මෙතන ලොකු ප්‍රශ්නයක් කරනවා. anemia එනකොට ankle edema ටිකක් එන්න පුළුවන් because of this sort of heart failure එකක් එන්න පුළුවන් නිසා. So this is answer here is pernicious anemia, right? So this is B12 deficiency. So මතක තියාගන්න B12 deficiency. So why do we say pernicious anemia? History එකේ පොඩ්ඩක් තියෙනවා vitiligo කතන්දර තියෙනවා autoimmune. MCV is very high, above 100. That is usually supportive. And remember, because of B12 deficiency, they can have an intramarrow hemolysis and also sometimes a pancytopenia because B12 is required for other cells also to divide and differentiate. So, ඒ වගේ ටිකක් අමුතු presentation එකක් එක්ක එන්නත් පුළුවන්, right? B12 deficiency. So, the answer here is pernicious anemia. 70-year-old hematology clinic එකට අවිල්ලා තියෙනවා MIs හැදිලා තියෙනවා antihistamines එක ඇඟ කසන නිසා හරි plethoric කන්න දැන් නිකන් polycythemia පැත්තකට යන වගේ කතියක් තේරෙනව නේද polycythemia තියෙනවා splenomegaly තියෙනවා hemoglobin වැඩි අරක මේක කතන්දර ගොඩයි white cell count platelet is also high that's seen in patients with PRV පොඩ්ඩක් අර ඉතුරු myeloid cell උත් පොඩ්ඩක් වැඩි වෙන ගතියක් තියෙනවා හරි. So this is PRV. PRV JAK2 mutation is what you see commonly. Most of them are JAK2 positive. Most of them. Sorry. So got a 75-year-old gone off her feet can and the Tabatilla. So hemolytic anemia ganna bari mokada pancytopenia නැති නිසා මේ චත්‍ර අනිත් එක තමයි පොඩ්ඩක් ඔය liver function උත් එහෙ මෙහෙ වෙන්න පුළුවන් B12 deficiency වලට. හරි. So මේ කතන්දරේ මොකක්ද මේ කියන්නේ? 75යි, right? hemoglobin අඩුයි, calcium වැඩි, creatinine වැඩි, renal failure තියෙනවා, backache තියෙනවා නේද? මොකක්ද මයලෝමා වෙන්න එපා මේක නේද? කිසි කතන්දරයක් නැහැ. එතකොට මේකේ බෙස්ට් එක electrophoresis initial investigation එක අපි එකපාරට මතකයිනේ bone marrow වලට පනින්නේ නැහැ. ඉස්සෙල්ලා අපි we have to demonstrate that there's monoclonal gammopathy and for that the second answer is the right thing and then you do there is already evidence that there is end-organ damage. Once you do that do a sort of a scan bones survey, skeletal survey for lytic lesions, and then bone marrow is the final one. But the first thing you need to do in this patient is demonstrate that there is a monoclonal gammopathy. This is a diagnostic criteria, not one single diagnostic investigation that you do here. Right. Excessive bleeding තියෙනවලු මෙතන මොකක් හරි එකක් අඩුයි. ඔව් sorry මේකේ මම දීලා නැති එකක් තියෙනවා ළමයි පොඩි මේ bleeding time prolong කියලා තියා ගන්න මේක. අර කන හිල් කළ කරන්නේ bleeding time එක prolong. So එහෙම කිව්වට පස්සේ so when the bleeding time is something that measures the platelet response. So there is a platelet dysfunction plus a factor VIII deficiency in this නේද? මොකක්ද ඒතර එහෙම වෙන්නේ? මොකක්ද උත්තරේ? 1 milligrams. So there's a platelet dysfunction plus a factor VIII deficiency. 1 milligram disease. That is a typical presentation. ලියා ගන්න එතන එක මට මිස් වෙලා bleeding time prolong කියලා තියා. මේ මොකද්ද මේක බලමු 28 year old මේ nausea vomiting අරක මේක තියෙනවා hemoglobin අඩුයි reticulocyte වැඩි bilirubin වැඩි මේක කරලා තියෙන කලින් නේද මම මේ මොකද්ද මේ what do you think is the most likely diagnosis? This is a very tricky MCQ. What is basically clear is that there is hemolysis, hemoglobin adui. MCV එක normocytic වගේ නේද? size එක. There is increased reticulocyte percentage, which is showing that there is hemolysis and the bone marrow is producing reticulocytes. And the bilirubin is high. ඔක්කොම හරි but Coombs negative. But hemolysis එකක් non-immune එකක් වගේ. නේද? hemolytic anemia එකක් non-immune එකක් වගේ. මොකක්ද උත්තරේ? ළමයි කියපම් බං බල කටහඬත් අහන්න ආසයි නිකන් මේ බ්ලැන්ක් ස්ක්‍රීන් එකට හැමදාම උගන්න එපා ඉලද මොකක්ද so this hereditary spherocytosis this abdominal pain katandare is actually නිකන් හංගලා තියෙන්නේ මොකද්ද biliary colic එකක් නිකන් biliary symptoms right biliary symptoms so nausea abdominal pain නරක මේක so I told you it commonly presents with gallstone disease right so dyspepsia as you know is a manifestation of biliary disease so here the answer is hereditary non-immune ai non-immune කිව්වේ Coombs test negative නිසා non-immune hemolytic anemia එකක් තියෙන්නේ මේ ලෙඩට right I think sorry right මෙන්න මේක 78-year-old female on warfarin for atrial fibrillation presents with melena so this is life threatening bleeding INR එක කන බැලේ INR කියුණත් patient life threatening bleeding තියෙන right melena so anything gastrointestinal bleeding intracranial hemorrhage intraabdominal all are life threatening bleeding එහෙම වුණාම වෙන කිසිම කතන්දරයක් නැහැ warfarin නැවතුවා vitamin K දුන්නා prothrombin complex concentrate දුන්නා වෙන කිසි කතන්දරයක් නෙවෙයි කරන්නේ හරි so stop the warfarin give vitamin K and give prothrombin complex concentrate to get the clotting factors back to normal hari if you don't have prothrombin complex concentrate give FFP right now what do you do if there are no signs and symptoms of bleeding or minor bleeding samahara velawata වැඩි ගණන් ගන්න the management depends on the INR value okay. If it's more than 10 you have to give them oral vitamin K 2.5 to 5 milligrams and stop the warfarin if it's between 4 and 10 මුකුත් ලොකුවට කරන්න ඕනේ නැහැ warfarin නවත්තලා outpatient follow up කරන්න පුළුවන් but consider giving vitamin K lower dose එකක් but එහෙම කරන්න අවශ්‍ය නැහැ no bleeding INR 4 to 10 නම් follow up කරන්න පුළුවන් right but here this patient has life threatening bleeding and clear melena so then your treatment is like this vitamin K stop warfarin and PCC that is the best if you don't have PCC give FFP හරි මේ algorithm එක වැදගත් ළමයි ඕක ප්‍රශ්න අහනවා හරි best response වලට right මේක මොකද්ද
excuse me
okay
sir මේ life threatening කියලා ගන්න පුළුවන්ද මැලිනා විතරක් තියෙනකොට
a life threatening melena මේ බලන්න 90/60 blood pressure tachycardia that is very significant bleeding hemoglobin අඩු වෙලා තියෙනවා melena එකේ life threatening තමයි ඒකට මොකුත් නොකරොත් මෙලා මැරෙනවා හරි okay 7 bleeding gums තියෙනවා කතන්දරයක් තියෙනවා නේ platelet count එක very low 20000 giant platelets තියෙනවා වෙන මොකුත් කතන්දරයක් නැහැ මොකද්ද මේ ITP this is ITP and ITP can cause giant platelets because like in hemolytic anemia when there is peripheral platelet breakdown the bone marrow starts producing immature platelets and releasing them into the circulation.
සයක මේ drug induced thrombocytopenia වෙන්න බැරිද?
Omeprazole වලට එන්නේ නැහැ වැඩි drug induced hypo. ඔය වෙන මොකක් හරි drug එකක් දීලා තිබ්බනම් හරි. Omeprazole වලට it's not a common thing. So common අර මේකේ best මේකනේ කියන්න ඕනේ. ඒතර most likely ITP. හරි. Right. එතකොට splenomegaly තියෙනවා white count එක ගොඩක් වැඩි. හරි. And you see various blasts තියෙනවා mature cells තියෙනවා myeloid cells නේද ඒක ඒවා තියෙනවා එතකොට මේක CML mutation එක 922 translocation is the commonest thing that you see BCR ABL mutation. Right. Last one 66-year-old diarrhea තියෙනවලු නේද hemoglobin adui, platelet adui, schistocytes. Schistocytes are what you get in these fragmentation syndromes. Right? Fragmentation. Diarrhea එක මේක තමයි infection වලටත් අදාළ දෙයක්. Diarrhea එක්ක ඔය fragmentation syndrome එකක් කියන එක මොකಾದ? HSTTP එන්න පුළුවන් සතා කවුද diarrhea හැදිලා? It's a fragmentation syndrome with renal impairment and diarrhea. Shigella වලට එන්නත් පුළුවන් E. coli නේ. O157 කියලා එකක් ඉන්නේ. උගෙන්නේ. Okay. Right. Any questions from hematology?
So G6PD deficiency වල splenomegaly එකක් වෙනවද?
නෑ. Somebody has pointed out a very good thing. කවුද? මේ අර මේ myeloma එකක් තිබුණා නේද ප්‍රශ්නයක්. ඒක ඇත්තට මටත් ඒක this is an acceptable answer. මේ වගේ එකක් වෙනවා exam එකේ. That's a good point. Now the patients come with neurological manifestation නේ. ඒ ප්‍රශ්නේ ඒක myeloma වුණාට ඒක අහන්නේ first investigation මොකක්ද කියලා නේද? එතකොට if somebody has even said MRI, that answer is acceptable because actually in a practical sense MRI එක කරන ඒ වෙලාවේ ලෙඩාගේ main priority එක මොකක් හරි neurological compression එකක් තියෙන එක relieve කරගන්න එකනේ. ඒතර එහෙම ලිව්වත් හරි ඇත්තට. MRI ගහලා තිබ්බත් that is also a good answer. Yes. මේ practical sense එක ඇත්තටම මේ MRI එක තමයි ඉස්සලා කරන්නේ. But MRI is more important in that context because the patient has some cord compression story going on. Okay.